Hi, this is Dr. Crawford. We're moving on to part 2 of my series on breast cancer. Last time we talked about DCIS, and today we're going to be talking about invasive breast cancer. So invasive breast cancer can occur when DCIS, or ductal carcinoma in situ, begins to go beyond the duct itself. So you see the ducts that are found in the mammary glands. What can happen is that if the cancer goes undetected, it can start going beyond that into the breast tissue. The same is true for a related form of breast cancer called lobular carcinoma. It can occur in situ, and if it progresses, it can start to spread. So the gland itself or the ducts can be the source of the breast cancer, either on site, not moving around, or spreading and invading the local tissue. Today we're going to be talking about invasive breast cancer. And this is called no special type because it's just a general characterization of breast cancer. The cancer cells have no specific features that would classify them as a special type in this categorization when examined under the microscope. Although deeper dive into the molecular genetics, we can find a lot of differences. This can be called invasive ductal carcinoma of the breast, and there is another form which is invasive lobular carcinoma of the breast. Breast cancer not otherwise specified. So we're going to be looking at invasive breast cancer. This is just a starting point for us to look in general at this type of breast cancer and what's involved and how it's treated. So let's take a closer look at the breast. The breast consists of lobes. These lobular glandular cells are where the milk is produced. The milk then moves into the ducts and then is secreted during breastfeeding. When some of these cells begin to grow abnormally, they can either occur within the duct, and that's called in situ, or they can begin to spread. And the abnormal cells can then begin to move beyond the duct or beyond the lobe into the surrounding tissue. So this is what we're looking for in a mammogram. We're looking to see whether or not the tumor cells, the abnormal cells, are restricted or whether they've moved beyond. So here's lobular. Here's the normal lobe, which contains these various glands that produce the milk, and here are the abnormal cells. This is lobular carcinoma in situ, and you can see that the abnormal cells are restricted to the lobes themselves. Now, when we move on to invasive carcinoma, this is the difference. In invasive carcinoma, we're moving beyond the initial tissue. Here's a comparison. Let me just pull this up for you. This is a normal lobe. This is the in situ, where it is still restricted to the lobe itself. And this is invasive, where now it's moving beyond. Invasive carcinoma is a big step. It is a big step because we are now moving beyond the original site of the tumor and to areas within the breast where we may have an issue with spread. So let's take a look at a normal mammogram. Here, this is an X-ray of the breast tissue, and you can see some lighter areas where you see the various components of the breast. And then we move to see a mammogram where there's a benign cyst. This is benign because you'll notice it has a very defined edge. There's no evidence of moving beyond that local abnormal growth. But ultimately, certain tumors may move beyond that. Here we see breast calcifications. Now, certain breast calcifications, particularly if they're very tiny, called microcalcifications, can be sites of cell death or necrosis, which means that cells are growing abnormally, and that's a red flag for cancer. Now, the difference between the benign cyst, which is very well defined and circumscribed within the breast, and breast cancer is the more invasive, more spreading, more open configuration. That is the diagnosis for breast cancer. That is the main difference. Now, what about the symptoms? The symptoms of breast cancer include, I just have to move this a little bit. The symptoms of breast cancer can involve a lump or thickening of the breast tissue. It can involve a change in the size or shape of the breast. It can involve a change in the texture, or a lump or swelling, changes to the nipple, sometimes a pulled-in effect, or some kind of discharge. Now, this by itself is not an indication of cancer. We have to take this further, and we have to take a look at what is involved, but it's certainly a sign that one needs to go to get an exam and see what's going on. So let me just move this up a little bit. Once you go for a mammogram, sometimes an ultrasound, which uses sound waves to record the different components of tissue. Particularly, you will need to do this if you have dense breasts. That's going to be a topic for another talk. But at any rate, once all this information is in, what are the pathology results going to tell you? If there is a tumor, it's going to tell you what type of breast cancer. Is it localized or invasive? Based upon whether or not it has spread beyond the starting point, or whether it is circumscribed and seems more like a benign tumor. What is the size? This can be measured. We're going to be talking more and more about the grade in terms of what's abnormal about the cells and whether or not it appears that this is a more advanced type of cancer, just based upon the pathology report. Again, there's a lot of molecular testing that can be done as well. Other tests that will be done is to see if whether or not the tumor is hormone sensitive. Does it respond to estrogen? Does it have an abnormal number of estrogen receptors? That's going to be very important. Also, in this talk, we're going to be looking at another type of receptor, the HER2/neu receptor. If the cancer is HER2 positive, then that will give us another indication of what we're going to do therapeutically. So this is how the tests are interpreted. Now, by histological screening only, most breast cancers would be of no special type. We have to then do further molecular analysis to see exactly what's going on. But we call them invasive if we can see signs of spreading locally beyond the site of either the duct or the gland. So when cancer cells are looked at under a microscope, there may not be any distinctive features that would allow us a further classification. But there's a lot of molecular testing that can be done today to give us a much better sense of what type of cancer is going on. Now, breast cancer starts when the cells in the breast begin to divide and grow abnormally. Primary breast cancer is breast cancer that hasn't spread beyond the breast or the lymph nodes. Today we're talking about invasive breast cancer, and if you take a look at the diagram of this breast, what you'll see is that there are nodes and vessels that move from, blood vessels that move from the, and lymphatic vessels that move from the breast tissue to the lymph nodes in the arms. And when the breast has a tumor that's beginning to expand, it's possible that some of those cells will get into the vessels and then into the lymph nodes that drain the vessels and then move into the circulation. This is where we're going to an invasive breast cancer that has the potential to become metastatic. Now, lobular carcinoma, invasive lobular carcinoma, is the second most type after ductal carcinoma. It accounts for about 15% of all breast cancers, and it starts in the lobules, as I mentioned before, and these are the milk-producing glands. This is more common in older women. So what's going to happen during the diagnostic phase is there will be a determination of whether or not the breast cancer occurs as a consequence of a ductal invasive carcinoma or one spreading from the glands. Now, it's going to be very important to do a look at hormones and the breast cancer. So as we talked about in video number 1, sometimes breast cancer cells contain estrogen receptors. These are called estrogen receptor positive or ER positive breast cancer, often called ER+. And these estrogen receptors bind to the hormone estrogen, and that helps to feed the cancer. It helps the cancer to grow. Hormone therapy, as we talked about in the previous cast is a treatment that stops the effect of estrogen. And there are many types of hormone therapy that are in use. So if you want to learn a little bit more about that, you should go back to part 1. Now, there's another form of breast cancer called HER2 breast cancer. And this responds to a growth factor, epidermal growth factor. And epidermal growth factor can also drive the abnormal growth of breast cancer cells. So some breast cancer cells have a higher than normal level of a protein called HER2, human epidermal growth factor receptor 2, on their surface. This will stimulate them to grow. These are called HER2 positive breast cancer. And about 1 in 5 of the invasive breast cancers, about 20%, are HER2 positive. So it's going to be very important to make a distinction as to what the hormonal status of the tumor is. So all breast cancers, following the initial diagnosis, will be tested to see whether or not they are HER2 positive. And this can be done in a hospital lab on the breast cancer tissue that's removed either during biopsy or surgery. And there are various tests that can be done, immunohistochemistry, for example, to see whether or not there is excess number of these receptors on the surface of the tumor cells. And this involves special staining for that particular type of receptor. And you're going to get a score. It's reported as a score of 0 to 3. 0 or 1 plus means there's not many HER2 receptors on the tumor itself. A score of 2 plus is borderline, which will involve a retest. A score of 3 plus means that there's an abnormally large number of receptors on the tumor, which results in this classification of HER2 positive. And this is going to mean that a different type of treatment is involved. Now, if your tumor is HER2 positive, you'll be offered a targeted therapy. This is a biological therapy that is specifically targeted to derail this abnormal growth of the tumor based upon the presence of abnormal numbers of HER2 receptors. And these types of drugs include trastuzumab or Herceptin, pertuzumab or Perjeta, or trastuzumab emtansine, which is Kidcikla. The names can get to you. Anyway, we're going to be looking at these different types of therapeutics. The most common is trastuzumab, which is called Herceptin in terms of the brand name. And then there are some similar brand names that have the same effects of this drug. And these drugs are going to work to block the receptor itself, and therefore drive down the growth of the tumor. Now, the HER2 testing is normally only done on invasive breast cancer. So if it's an in situ, that's not necessary. But once it is invasive, they're going to test for HER2. And then they're going to review the patient record to see whether or not trastuzumab or Herceptin is suitable. So if certain people have heart problems or high blood pressure that is not well controlled, may have a different prescription. So that will be determined on an individual basis. And there are various ways to give the trastuzumab. It can be given as a drip or an injection. And it's usually combined with chemotherapy because the chemotherapy also is used to block the spread of the tumor. We're going to have a special, separate podcast on the how chemotherapy is used to treat breast cancer. So these hormonal therapies can be used in addition or along with chemotherapy and even radiation. If you're receiving the Herceptin as a treatment, you will be using it as long as it continues to keep the breast cancer under control. So again, that's decided on an individual basis. Pertuzumab is yet another targeted or biological therapy. Its brand name is Perjeta, and sometimes they're used as a combination. So trastuzumab and pertuzumab combined to give it the brand name Phesgo. And this is sort of a two-punch approach. You're going to go after that receptor with two different drugs, and it will depend upon the patient and the way in which the tumor is growing. Those decisions will be made that way. These drugs all work in the same way. They block the HER2 receptor. There's another drug that's called trastuzumab deruxtecan, and that is a combined approach. It combines a chemotherapy drug with the trastuzumab. So in other words, you're going to get the effect of hitting the receptor and also hitting the tumor with chemotherapy. And the name of this combined drug is called Enhertu, the common brand name. So you may be offered trastuzumab deruxtecan if you have HER2 positive breast cancer that has spread. So this is typically used for cancers that have spread. It's a more powerful approach. And it's given to people who have already had 2 or more treatments for HER2 positive breast cancer. So it's called a second line approach. Also, what's important about this drug is it can have a bystander effect. It can help kill surrounding cells as the chemotherapy diffuses from the targeted cell to the surrounding tissue. So that can also be very important in treating the invasive tumor. So trastuzumab emtansine is yet another therapeutic. It's called frequently called Cancert, and it is used again for in an outpatient basis for a number of weeks. And again, this is important for giving a two-pronged approach for biological therapy. Now, another drug is tucatinib. And tucatinib is, let me just make this a little bit bigger so you can see it. Tucatinib is a cancer drug that's a tyrosine kinase inhibitor. And this is a little bit more complicated. Just keep in mind that tyrosine kinases are enzymes that promote the growth of cells. So this is a targeted approach to destroy the ability of the tumor cell to grow. So tucatinib is yet another biological therapy. Its brand name is Tukysa, and again, it may be offered to you if you have HER2 positive breast cancer that has spread. So it's giving a two-pronged approach. You use a drug that's going to target the receptor, and then you use another drug that's going to target the tyrosine kinase, and this two-pronged approach hopefully will give a double whammy to the tumor. There are other combinations that can be used as well. Now we're talking about metastatic ER-positive breast cancer. There are other targeted therapies that can be used as well. So these would be used for HER2 negative. So these are patients that don't have the HER2 receptor, but they do have the estrogen receptor on their breast cancer. And these would be breast cancers that have spread. And the drugs include abemaciclib, and that is Verzenio, alpelisib, Piqray, everolimus, Afinitor, palbociclib, sorry about that, Ibrance, and ribociclib, which is Kisqali. These are a newer class of drugs that are used for invasive breast cancer. Abemaciclib is a targeted to a specific abnormality in the tumor. It is used alongside hormone or endocrine therapy, such as Herceptin, and the brand name is Verzenio. And this again is a CDK inhibitor. It's a growth inhibitor. And they block the action of this enzyme called kinase, which stimulates the cells to grow and divide. So again, you're going to be getting a two-pronged approach to derail the growth of an invasive cancer. The next class of drugs would be abemaciclib or Verzenio. And this is used to treat breast cancer again, that's ER positive and HER2 negative. And this is used in patients that have early primary cancer, but where further molecular analysis suggests that the cancer may have a high risk of coming back. So you want to hit it with a really high power growth inhibitor. It can be used as adjuvant, meaning it's along with other treatments such as surgery. It's used for breast cancer that is spread to the tissues and lymph nodes around the chest and neck and under the breastbone. So this is definitely used in the case of an invasive spreading cancer. It's also used for breast cancers that have spread to other tissues and organs in the body. This is given as a tablet, and many of these biological therapies, are given as tablets. They're usually given alongside the hormone therapy, and exactly what treatment protocol is prescribed by the physician will be determined by an individual and their case. Some women with primary breast cancer will be given these drugs along with the aromatase inhibitors that we talked about in talk number 1. If you have not been through menopause, you will also have a treatment involving ovarian suppression in order to enhance the effect of these drugs. And again, that I talked about in the previous talk. The next drug is abemaciclib, and this is for locally advanced or secondary breast cancer, also used sometimes with an aromatase inhibitor. And if you have not already had hormone therapy, fulvestrant if you have had an aromatase inhibitor for locally advanced secondary cancer. So again, these are decided. These are combinatorial treatments, combinations of approaches, depending upon the patient history of treatment and the type of breast cancer. If you have primary breast cancer, you'll usually take abemaciclib for 2 years alongside the hormonal therapy. So this is an ongoing growth control preventative, essentially, to prevent further spreading of the tumor. After this, you stop taking the abemaciclib, but you'll continue the hormone therapy for up to 10 years. Depending upon your particular situation. If you have secondary breast cancer, which has spread to other tissues, you'll have abemaciclib alongside hormone therapy for as long as the treatment seems to be working. Okay. The next is alpelisib, which is a targeted therapy. It interferes with processes, again, that help the cancer cells grow. And these are the kinase inhibitors. So they're more general in terms of the growth properties. The kinases are not as specific as the ER estrogen receptors. They fuel a number of types of cancer. But this particular drug, called Piqray, branded name, is used for a general way of blocking cell growth using these tyrosine kinase pathways and inhibiting them. The Piqray is used to treat breast cancer that's estrogen receptor positive, HER2 negative, and has documented changes in these kinase enzymes that drive tumor growth. So not all tumors have these changes, but if that is present during the biochemical testing of the tumor, you may be prescribed this drug. And it's often given alongside the hormone therapy drug fulvestrant. So you may be offered alpelisib if your breast cancer has a kinase gene mutation. So one of the areas that we're going to be focusing on in a future talk is mutations or changes in genes that can cause and also affect the progress of breast cancer. So there are some tumors that have an abnormality within this kinase gene. So if that's detected in various types of early testing once the tumor is diagnosed. And if you have already had hormone therapy along with the CDK4/6 inhibitor, Piqray can be prescribed if after that treatment the tumor has spread to the tissues and lymph nodes around the chest, neck, and around the breastbone. And this is called locally advanced breast cancer. It can also be used for cancers that have spread to another part of the body, such as the bones, the lungs, the liver, or the brain, sometimes called secondary. So Piqray would be an approach to more advanced breast cancers hitting that CDK kinase gene. Now, another very frequently used drug is called everolimus or Afinitor. Afinitor, again, is another example of a targeted biological therapy. They block, again, the spread and growth of cancer. It is used in combination with a hormone therapy, exemestane. Everolimus may be offered as a treatment for postmenopausal women with ER-positive, HER2-negative, locally advanced in the chest area, or secondary moving to other organ systems of the body whose breast cancer has come back during the initial course or after the initial course of hormone therapy drugs, letrozole or anastrozole. So it's not usually a first-line drug for primary breast cancer. This type of drug has a different target. This target is called mTOR. It's another pathway within the cell that drives cell growth. This mTOR pathway is seen abnormally in many types of cancers. And so this would be yet giving another hit to an important growth pathway within cancers, including breast cancer. And this would be, again, a second-line treatment for more advanced cancers. Everolimus may be offered to postmenopausal women, as I mentioned before, and it's used mostly in women who have been through menopause. Now, yet another drug commonly known as Ibrance or palbociclib is a targeted biological therapy used to treat breast cancer, taken again along with hormone therapy. It's the palbociclib is the drug's non-branded name. Ibrance is the commonly used name for branding. Again, it's another CDK inhibitor, again blocking the kinase enzyme. Ibrance is used to treat cancers that are estrogen receptor positive and HER2 negative. It's also used if your breast cancer has spread to the tissues and lymph nodes around the chest, locally advanced, or spread to another part of the body in secondary breast cancer. It's not currently given for primary early breast cancer. Again, these tests are going on to see if it might be useful in preventing disease progression, but the answers are not available yet. So this drug is usually, again, given alongside the hormone therapy. You may take this drug with an aromatase inhibitor if you have not already had hormone therapy for locally advanced or secondary breast cancer. With fulvestrant, if you have had hormone therapy for locally advanced or secondary breast cancer. And some people who have had hormone therapy for primary breast cancer and who now have locally advanced or secondary cancer may be offered palbociclib with an aromatase inhibitor or fulvestrant. So again, this is a patient-by-patient approach, depending on the patient's category in terms of cancer stage and grade, and also to be given with a hormone receptor inhibitor to give it that two-pronged approach to treating the cancer. Yet another drug given for invasive breast cancer is ribociclib, or Kisqali. This is yet again a targeted biological therapy drug. It's given alongside the hormone therapy that we talked about before. The brand name is Kisqali. And again, it's yet another CDK kinase inhibitor blocking the action of kinases which drive breast tumor growth. So it's a two-pronged approach. Again, this drug is used for patients who are estrogen receptor positive and HER2 negative. And this is frequently given if the breast cancer has spread to tissues and lymph nodes locally or to other organ systems in advance, and it is not given for primary breast cancer. So that's yet another consideration. So these drugs are basically a new generation of drugs. They have been given to patients who have received the traditional chemotherapy and hormone receptor blockade, and as ways of targeting the cancer further. So what we want to do then is to study breast cancer in terms of the multifaceted treatments that can be used, and also to understand what the meaning of these different drugs is and how they are applied. In future podcasts, I'll be talking about what are the side effects, how actually do they work, and really putting together all the pieces. So this was an introductory talk on invasive breast cancer and the types of newly developed, I say newly in the past 20 years, developed targeted therapeutics that are built upon our understanding of what causes breast cancer, what genes are involved, what kinds of pathways drive the tumor's growth, as a way of specifically going after the tumor while hopefully not harming any other tissues of the body. This approach is not entirely successful. It does have side effects. And obviously, breast cancer is a disease which is not always curable. But we will be going into more depth in future talks about invasive breast cancer and all of the treatments that occur. I hope you have learned something from listening to me today.